thank you all for inviting me to speak at this conference today. I've been to some of the workshops and I thought it was a brilliant program, and I dare say that if we were to have a conference like this in Germany, I don't think we'd have 70 delegates, because evaluation doesn't seem to be valued as highly as it is over here, and that's good news to me, because I've been in evaluation research for the last 7 or 8 years, and hopefully this whole thing is going to take off in Germany as well. So thank you for inviting me to present our results, and as Helena said, obviously, as I'm a medic, my research was done in the context of medical education. So one of the questions I will have for you afterwards is whether what I'm going to tell you will be transferable to your contexts, which are not all medical contexts. And that is the most interesting question to me now. Will we be able to transfer our ideas on outcome-based evaluation to other areas of higher education? Right, what's the main purpose of evaluations? I mean, this is a question that I shouldn't ask you because you're all involved in this business, but I've defined it as improving teaching, which is the same as increasing teaching quality. Obviously, there's always other definitions of the purpose of evaluations, and for some it may be ranking universities, for some it may be ranking courses or departments, and for others it may it may be ranking teachers even, and maybe rewarding them. But in the context of my presentation, the purpose of evaluation will be perceived as improving teaching or increasing teaching quality. Now, if we are to increase teaching quality, the first question is, what is teaching quality? And I've heard a lot about this during the workshops here, and I've heard other definitions than the one that I'm going to come up with now. One, and I think this is one thing that you all mentioned today already, is structures, so structural aspects of teaching. The other one is processes. Teaching process is another very important contributor to teaching quality. Then there's teachers, and we heard about that a bit as well. And finally, there's the dimension of outcome, and I think we haven't discussed this in great detail today. We've heard about a few questions touching upon that issue today, but I think I might be able to give you a few new ideas on outcome as a surrogate for teaching quality. Now, all of these 4 dimensions can be assessed separately. There have been questionnaires developed for the assessment of structures, for processes and for teachers. I'm not aware of any questionnaires on outcome so far, but you can assess all of these separately. At the same time, most of you, and obviously of us as well, are using questionnaires with one single question. There's always something like, how do you rate the overall quality of the course or of teaching or of the module or whatever? And this implies that apparently these borders can be made, I'm looking for a word now, so they can be made less solid. What's the word for that? Yeah, thank you. By using global ratings, and we think that we can use global ratings to assess all of these areas. Now, this is something that I don't believe, but it's something that we do all the time. And what I want to do is I want to share with you my views on evaluating outcome, and I think it's completely different from what we get for the other areas or the other dimensions of teaching quality. And that's why global ratings can't be our only surrogate of teaching quality. Talking about student overall ratings or overall course ratings, I've put together a slide showing you the results of a study we did back in 2012. Now, our clinical curriculum is a 3-year curriculum made up of 21 modules, each of which lasts between 2 and 7 weeks. And at the beginning of each of these modules, we asked our students whether they thought that this is an important module, whether they were looking forward to participating in the module, and whether they'd heard that this is a good module from their fellow students or their peer students. And after the module, and that's usually a few weeks later, we asked them whether they liked the interdisciplinary approach, whether they thought self-directed learning was fostered during this module, whether they thought they'd learned a lot. And I'd like you to pay attention to this item later on, because this is what you get when you ask students whether they think they've learned something, which is completely different from what they've learned. And this is really interesting. So by asking this question, you have no idea of how much students have really learned. And I'll come to that later. And I just wanted to point this out now because it's going to be really funny later on. We also asked about structure, continuation, that's should this module be changed or should we leave it as it is? And there's a famous overall rating down here. What you're going to see now is correlation coefficients between student ratings for the 21 modules. And when we compare ratings for these three things asked before the module, you see there's a very high correlation between the three, which is quite expectable. Someone who thinks this is important and has heard that it's meant to be a good module will be looking forward to it. So that's quite straightforward. Likewise, but a little less surprising, there were high and significant correlations between all of these items. And, well, this begs the question whether a module that has a good structure inevitably also means that students have learned a lot. Is that necessarily the case? I'm not sure about this. What do you think? What's your take on these correlations?
Yeah. I think if you structured your module well, students will tend to learn what you wanted them to learn.
So if we turn this around, in a module where students have learned a lot, you can be sure that it was structured well.
I don't think that necessarily is.
Right. So it's difficult, actually, to draw causal inferences from this, really. It is difficult, isn't it? And actually, to be honest, I'm not sure what this means. It's just that we found this. And we were even more surprised when we found that student ratings before the module correlated highly with student ratings after the module. And that led us to believe that something might be at work which we hadn't really grasped at the time, but actually we thought maybe we are measuring a completely different underlying construct with all of these items. So instead of actually looking at 6 different areas, we are probably looking at one area, which is, what do you reckon? What are we actually assessing with these questions, which are all highly correlated to each other? What are we measuring there? What do you think? Any ideas? Motivation and satisfaction, that's what we thought as well. I don't know, but I think there is a slight chance that we're actually just measuring student satisfaction. And that would mean that these are not different constructs, but they all actually show up in this underlying construct that we haven't really assessed, except for this last item, overall rating. And also, given the high correlation between ratings before the module and after the module, we thought there might be some confounding by halo effects or expectations or stuff like that, which also makes it difficult to interpret these, especially the overall rating, as an indicator of high quality teaching. You're just not too sure about this. Right, the research question that came out of this was, given that global ratings are suboptimal indicators of teaching quality, and given that there are 4 dimensions of teaching quality, which I've just shown you, and each of these can be assessed separately, and given that we've already got good questionnaires for structural, procedural, and teacher aspects of teaching, especially for medical education, there have been a number of questionnaires developed for structural aspects, and I can list at least 10 questionnaires on teacher performance in medical education alone. Given that we've got all that, is there an adequate outcome measure? Now, what do you think would be an adequate outcome measure for medical education? On the level of individual modules, that is.
Survival rate of patients.
Yeah. But that's the problem. I mean, after the first module, it's difficult to see that. But you're right, yeah, of course, that would be the ultimate one. I've found a paper that was published about 10 years ago by Bloomberg, and he says, oh, hang on, Phyllis, could that be a she? I think it's a she, isn't it? So she says there are 3 dimensions to outcome in medical education. One is the educational outcome, which in this case means learning style. So students learn how to learn, which is completely different from students learn content or subject matter. Then there's clinical career outcomes. This is the competencies, CanMed's framework and stuff like that. So competencies used for your occupation. And then finally there's environmental outcomes, and these pertain to the university itself. This is about the learning climate and the culture that's embedded in a university where teaching is valued as much as research is, for example. So given that we've got these three domains, to keep it short and simple, I decided to look at only one domain of these, and that's competencies. So learning outcome of students, not learning outcome regarding learning style and not regarding culture. I'm now just going to talk about learning outcome for students on the level of competencies. Right, so let's take a look at what German universities think how this can be measured, so how student learning outcome can be measured. There has been a position paper published in 2007 issued by the Associate Deans for Medical Education in North Rhine-Westphalia. I have been asked to say something in German here, and I will just let you know that this is actually called Nordrhein-Westfalen. And there you can see we've got a very melodic language there. So anyway, what they said is if you want to know the overall outcome, learning outcome, which is termed E here, and STEX, that stands for state examination, which is our high stakes examination at the end of our studies. You simply take the number of items answered correctly in this 320 item multiple choice exam and divide this by the number of examinees, and you arrive at this value. And you can use that to compare the 7 different medical schools in Nordrhein-Westfalen. That's it. That's learning outcome for you. Fantastic, isn't it? One thing that strikes me about this is that, you know, I studied medicine in London for a year and I had to take an OSCE examination. These OSCEs haven't really taken off in Germany. We've now got a few and they're becoming more popular every year, but still the final high-stakes exam for medical students in Germany consists of 320 multiple choice questions. That's all we have. And there's also an oral exam which is quite problematic in that there are no standards for this oral examination. So a teacher would just come in and say, okay, today I feel like asking you something about acne. So what you see, it really is problematic. So all we've got is this, and this is used to rank universities and to allocate funds to universities. Strange. Anyway, it looks very simple. Outcome equals exam performance. Now, there's another paper that was published 3 years later. It's about school-specific assessment in German medical schools. And school-specific, it may be the wrong translation of what these guys are talking about. This is about examinations held at medical schools, but not high-stakes medical education exams, because they are organized on a state level, whereas these are organized within medical schools. So this is what this article is about. And I've tried to translate one of the main conclusions of their paper, and it reads, some medical schools have taken steps to facilitate quality assurance of exams. This is funny, isn't it? However, there is some concern that overall written exams at German medical schools rarely meet international quality standards for summative exams. This is true. It's sad, but true. So how can you use exams to measure learning outcome? It is difficult. It's not that simple, after all. In order to be valid, exam results need to be objective and reliable. I mean, that's easy. It's like carrying coals to Newcastle, isn't it, saying that? Another prerequisite for the validity of exam results is complete coverage of the underlying construct. It's a bit more tricky, this one. So you need to be sure what exactly you're after. So what's the underlying construct of your course, of your module, and of your program? And that is not that easy. For doctors, it can be the professional doctor or the physician, the reflective physician. It could also be the researcher. And as a medical school, you have to choose which one you're going for, really. But anyway, once you know your construct, your exams need to cover all of that construct. And that means the exam could be quite vast and could be quite a long one. In addition, exam format needs to be aligned to learning objectives and teaching formats. And there have been a few instances where we have used written tests to assess practical skills, which apparently doesn't make any sense, but we still do it because written tests are so easy to do and they're objective and everything. MC questions, you know what I'm talking about. Right, and the final thing, which I think is most important here, is that performance gain or change in knowledge, skills and attitudes during a module or a course can only be assessed if initial performance levels are known. So in effect, you'd have to take 2 exams, one at the beginning and one at the end of the module. And the logistics of that are quite complicated. So we can't do that. Now, given that exams at the end aren't really valid, or some of them aren't, and we don't have any information on student performance at the beginning of the module, what do these exams actually tell us? This paper, published in 2008, tried a new approach that we have then used to develop our own evaluation tool, exploring the learning curve. So these guys are talking about a learning curve, and what they did is they asked about 533 students to self-rate their knowledge on a number of subjects, and these were medical students, and these self-assessments were then compared over the 4 years of medical education in this program. Now please note that these are singular self-ratings. So students in this year self-rated their knowledge here, students in that cohort, and they've got nothing to do with each other. So they're completely unrelated. It's not longitudinal, this is a cross-sectional thing. Still, the authors say the steepest difference between MS2 and MS3, right, that's here, professionalism ratings remained relatively stable. Right, okay, that's fine. But of course, if you're a psychologist, you're going to say self-assessments, are you joking? Self-assessments, self-ratings are so unreliable. How can you use those? Right, it is true. A number of studies have shown, and these are quite old ones, that the average correlation between self-assessments and objective ratings is only 0.4, which is not too good. And depending on the type of study, you get values between minus 0.05 and plus 0.8. So that is not ideal, and there are loads of influencing factors apart from gender and subject matter, also the study design, and last but not least the design of the data collection tool used in these studies. So singular self-assessments collected at one point in time aren't really that informative. These authors, it's the same study as the one that I showed you before, have also done something else. They've also asked students to self-rate their knowledge at time point 1 and then at the end of the year. So they could now compare the difference between the beginning and the end of the year. And this graph shows the % change of knowledge and attitudes derived from these data. And as you can see, there was a huge increase or a huge change for most of the subjects in the first year, whereas this was quite small in the final year, which is easy to believe because students in the final year would have learned a lot already, so the absolute change you can expect wouldn't be that big. Also, going back to that slide, you can see that they all started on a fairly high level. On this scale from 1 to 7, they started out with an average of 4. So it's quite easy to believe that there hasn't been much change between year 3 and year 4. Okay, anyway, we thought that measuring the change in knowledge, skills and attitudes would be a nice approach to evaluating student learning outcome. And this is why we took this approach to the next level. These 2 papers are the basis of the rest of my presentation, and if you want to take a look at those, you can download them from the internet, and if you don't have access to these journals, I'm sure it'll be no problem to make these available to all delegates at this conference. The basic idea we had was that given that the validity of singular student self-assessments is limited, and given that within a given individual the ability to self-assess is relatively stable over time, and that's the interesting bit here, we can use the difference between student ratings provided by the same students at different time points to estimate learning outcome. Now you have to keep in mind that more advanced students will have better knowledge to start with, so we will have to correct for that or adjust for that in our analysis. But still, let's see what we can come up with. Measuring learning outcome on the level of specific learning objectives, and that's the other important thing, it's not an overall rating. It's not a question like, do you think you've learned something, or I think I know a lot now and in a few months' time. We have to assess this on the level of specific learning objectives, and that requires these objectives to be clearly operationalized, and that is quite a daunting task. But once you've done that, you've got a nice set of learning objectives to be assessed by medical students, and then they will tell you how much they know. Our data collection tool was an online survey tool, and students were invited to self-assess their individual performance levels at the beginning and at the end of each teaching module. Statements used for self-assessments address the following 3 domains, which are typical for medical education: factual knowledge, practical skills, and effective learning objectives, including professionalism. And I'm pretty sure that you can probably come up with similar domains for other higher education areas as well. There's always factual knowledge, there's always practical skills, and I think there's always effective learning outcomes as well. So I think it would be easy to actually draw a blueprint of these things and these learning outcomes for other areas as well. Data were analysed on the level of the entire student cohort. So rather than going for individual comparisons, which we did, but which produced worse results, we went for aggregated data, which means that student self-ratings were aggregated and mean values were used to calculate performance gain. How did we do that? I'm going to show you in the next slide. But first, we need to remember that more advanced students will provide more positive self-assessments than first-year students, as I pointed out earlier. So the pre-post differences in mean values are bound to be smaller in more advanced courses. And that places teachers in those courses at a disadvantage. So we needed to adjust for that, which we did in this formula. It's fairly simple. The comparative self-assessment gain, that's CSA, comparative self-assessment gain, is a percent value between minus and plus 100%, and is calculated as the difference between the 2 mean values, pre, minus, post. And the reason for that is that in Germany, 1 is the best mark and 6 is the worst. And I'm aware that you use a different coding system, but never mind that. It really doesn't matter. If you just turn this around, you get the same result. But that's why the pre-value will be higher, will be something like 4 or 5, and the post value will be smaller, thus better. You just need to know that, because otherwise you're going to be confused. And this is the adjustment for initial knowledge, where dividing by the pre-value minus 1. The minus 1 only comes about because the scale we used was anchored at 1, not nil. If it had been nil, then there would just be the mean of the pre-value. So that's the only difference. Now I'm going to talk you through a few examples so you can see what this formula actually does. Here's a pre-rating, a post-rating, and I'm only going to display mean values with no standard deviations here. Then there's going to be the absolute difference, the adjusted pre-rating, and the calculated CSA gain. Now, with a pre-rating of 5, on a scale from 1 to 6, 5 is not very good, and a post-rating of 3, you get an absolute difference of 2. The adjusted pre-rating is 5 minus 1, that's 4, so the gain is 50%. All right? Easy. Next one. Pre-rating 4, post-rating 2.5. Now, the difference is only 1.5, so it's smaller, but these students knew more when they entered the course, so they were better to start with. As a consequence, this smaller difference produces the same CSA gain because the pre-rating is adjusted to 3. And that's the whole idea of adjusting for initial performance levels. And the same is true here. If you start out by 2, and 2 is really good, and you improve to 1.5, that's only a 0.5 difference, but as we're dividing by 1, it's still a 50% increase. So by doing this, we can avoid advanced modules to be disadvantaged. And finally, the nice thing is, wherever you come from, if you end up at a 1.0, a mean value of 1.0 at the end of the module, so each and every student says, I know it all, and they all tick the 1. That means you'll get 100%. And it doesn't matter where you're coming from. It'll always produce 100% because there's no way of getting any better than every student saying they know it all. Right. This is what our teaching coordinators get. Please don't try and read all of that. As you can see, this session is being filmed, and I think you'll all have access to the video of it, so you can laugh about my language problems, and you can also read through these slides because these slides will be provided with the film. But just to give you an idea of what's happening here, these are mean values before and after the module. Again, 6 is a bad and 1 is a good self-rating. These are just the self-ratings broken up by the 6 categories on the scale, and this is the calculated CSA gain. And all I wanted to show you with this slide is that we can distinguish between high, medium, and low CSA gains for the skills domain, the cognitive domain, and the affective domain. So we can look at all of these domains, and we can identify learning objectives with a high, a moderate and a low learning outcome. Let's take this one for example. It says, I know which agents can be used to treat urinary tract infections. Now you'd want your doctor to know about this, wouldn't you? Now during the module there was really no difference there, is there? So the gain was 2%, which is nothing really. So what we did when we got this result, we called the course coordinator and asked her what was going on there. And she then said, and we didn't know about this before, and she then said, all right, I know. All right, I know. The lecture was cancelled because the lecturer wasn't there. And that was the first indication of validity of our tool. So it actually tells you when students haven't learned something. It does. But of course, what you need to do first is you have to come up with these learning objectives. And that's the thing that actually takes most time in the whole thing. Right. That was the first indication of validity. I've got another example here. We were comparing CSA gain for 15 learning objectives in my module. That's a cardiorespiratory module, a 6-week module in the 4th year. We were comparing these learning outcomes in 2 consecutive student cohorts, summer 2008 and winter 2008-2009. And each dot represents one specific learning objective. If the whole approach produces valid and reliable data, we would expect some form of correlation. And here it is. It's not too bad, 0.98. Now, is there anything you'd like to comment on when looking at this graph? Any criticism, any questions? Anything you don't believe, maybe? So there are 15 learning. This is only 14 dots. So where's dot number 15? It's up here. Right, what happened there? This dot. Sorry? It's an outlier. Yeah. Could be. But this is an intentional outlier. The thing is, this is the learning objective I can interpret or I can read an ECG. Now, what happened is, in summer 2008, I realized that my students didn't really learn a lot about ECGs in my course. So I changed the course. Instead of 8 lectures, I had 8 small group teaching sessions there. And I also had a heavy, really difficult final summative exam they all had to take. And by that, and I've got objective data to prove it, by that I managed students to learn much more than they did in the preceding term. And in winter 8-9, this increased from 50% to over 80%. And that's another indication of how this tool works. It shows you immediately what happens due to changes in your courses. So when you change something, you can see it. So if something doesn't happen, you can see it. And if you do something to improve your course, you can see it as well. So these were the 2 first indications of validity, and we then set up a trial where we compared subjective CSA gain, this is what I just showed you, with objective CSA gain. In order to be able to do that, we took 34 or 33 learning objectives and calculated CSA gain, just as I showed you before, and we also created 1 true-false item question for each of these 33 learning objectives. And as each of the true-false items had 5 statements with them, we were able to score them the same way that we scored student self-assessments, because this is a scale from 1 to 6, and that's a scale from 0 to 5. So we were able to compare the 2 and calculate learning outcome for both measures. And this is the correlation. Obviously, it's not as straight as this one, but still, it's 0.8, so not too bad. So by this, we think there is a good correlation between subjective and objective CSA gain, so you don't need to have assessments or exams at the beginning and the end of the course, as we did here, because it's just too much work. It's enough to ask students how much they know at 2 time points. And you've seen this table before. Do you remember? That's the one that I showed you at the beginning of the talk. But now there's another column. It's the CSA gain column. And please don't be alarmed to see that there's a minus here all the time. That's just because CSA gain is better if it's positive or if it's higher, whereas all the other ratings are better if they're lower. As you know, 1 is a good rating, 6 is a bad rating. So that would explain why it's all negative. Just get rid of the negative sign. But as you can see, there are weak correlations here. Most of these are not significant, and that's a difference to all the other ones. So I think what we can say from these data is that the CSA gain is different from all the other things. Whether it's any better, we don't know. The only thing we do know is, other than all the other 6 items, CSA gain is not related to overall ratings. And that's interesting, because it shows that even if students think this was a very good module, and I'm going to give you a very good mark for that, it doesn't necessarily mean that they've learned a lot. It doesn't have to mean that. It means maybe it was fun, and maybe I've learned something, and it's 0.4, so that would explain 16% of the variance, so that's okay. But there are other factors which are important for learning outcome, and you can actually capture these factors on the level of individual learning outcomes in the CSA gain. And now the final question we had, and that we answered last year, was whether we actually needed 2 time points for data collection, because you always lose people, and you'd have to be able to identify them, so you know who took both surveys. That's a bit tricky. So can't we just have one data collection point at the end of the module where we ask students, now how much do you know now, and how much did you know 6 weeks earlier? Now, if you are a psychologist, you're not going to say, no, there's such a thing as a response shift bias, and that is going to hugely impact on your data. So we assessed this in this trial, where we took my 6-week cardiorespiratory module, and we asked students to rate their performance level in a true pre-test, so on the first day of the module, and then on the final day of the module. And this is the prospective performance gain that I just showed you all the time. You've seen that already. We also asked students to provide a then test on the final day, and we asked them to rate their initial knowledge and skills and attitudes retrospectively on the same day. And this was the retrospective performance gain. We'll now take a look at the results. This is what we got. This is prospective, this is retrospective, and although this doesn't go through the nil, it's still highly correlated. So although you get slightly inflated results with the retrospective method, the correlation between the two is still very good. So all you have to do is adjust for this by saying, okay, maybe it wasn't actually 60%, maybe it was 57%, but this dot is still better than that dot. And that's the interesting bit. That's what you want to know. So to summarize all that, I showed you those 4 dimensions of teaching quality. And I think outcome could be one important measure of teaching quality, and it should be defined by the content that you are intending to teach. Now, one way of assessing student outcome, learning outcome, is by using exam results. But as I said, disadvantages of that approach are the logistics, if you have to take 2 exams for each module, and also validity, at least in the German context, where many of these exams aren't valid. Another option would be singular self-assessments. That's what Thompson and Rogers did, but the disadvantages there are there is loads of confounding for singular self-assessments, and I showed you some of those. And also, again, these confounding factors call into question whether singular self-assessments are in fact valid. And that's why we've come up with this idea of comparative self-assessments. And obviously, because I'm trying to sell you something here, I'm only going to mention the advantages of that. Psychologically, it's practical and it's reliable and valid, at least for medical education. And that takes me to the last but one slide. Estimating student learning outcome from comparative student self-assessments produces values ranging from minus to plus 100%, takes initial performance levels into account, provides results for different domains of teaching, that is, knowledge, skills, effective learning objectives. It does not require students to enter personal data, because you can now only use the final data collection point, and there is no need to link student data to each other. And finally, this approach helps to differentiate between learning objectives with favourable and suboptimal learning outcome, thus facilitating an increase in teaching quality, and that's what we wanted at the outset. However, there are a few questions to be answered. The next steps would be future studies investigating whether the approach of outcome-based evaluation can be transferred to subjects other than medicine. So if anyone in the room feels intrigued to try this, please get in touch and we can set it up. And as far as I know, EvaSys are now trying to create a plugin that will allow you to just enter your questions, and it'll come up with a report, that colourful picture I showed you, automatically. So you get exactly the report, the same one that we get, and you don't have to do any calculations. It just comes up as that. And as soon as I get the time to write it all up, it's going to take me another 2 or 3 weeks, it's going to be available to everyone, really. And I'd be delighted if a few people would be willing to try it and get in touch with me. A next question would be if and how CSA gain and other evaluation data. Obviously it can't be the only one, and it shouldn't replace other methods. That's completely clear. I don't want to replace anything. This is just another dimension that can be added value to what you're already doing. So how can these be merged to facilitate a 360 degrees assessment of teaching quality? How outcome-based evaluation results can serve as a springboard for enhancement activities, and that speaks to some of the things that we've discussed today. It's not enough to just see, okay, we have failed to teach our medical students which agents to use which agents to use to treat a urinary tract infection. The next step would be to then talk to course coordinators or talk to medical students and say, what went wrong here? Is there anything we can improve so you actually get that learning outcome that we were looking for? So it's not enough to just collect the data. Obviously, they would form the basis for discussions. The next question is how CSA gain data can be used to inform curriculum reform and faculty development. And we've only started doing that by creating a questionnaire for teaching quality on the level of individual teachers, and we're now comparing those results with the results we get from learning outcome of students taught by exactly the same teachers. And it's interesting to see that there are teachers who would get really good marks on the teacher questionnaire, but learning outcome of their students would be quite low. It's not always like that, but we've got a few examples of teachers with the best marks for their teaching qualities and the lowest marks for their students' learning outcome. And merging these would be very interesting indeed. And finally, I'd like to know whether novel approaches to data collection have the potential to further reduce the risk of over-serving students, because, you know, we've got 21 modules, so in the course of 3 years, medical students would be asked to complete 21 of these lengthy questionnaires. There are 30 questions in each of them, so it's quite long. But there is new research from the Netherlands indicating that if students are asked to rate their peer students' knowledge, it can be just as good as rating their own knowledge, and you can reduce the number of students needed to get valid results or reliable results by about a quarter, which would be very interesting indeed. So we could save students time here without having worse data. So that's all I wanted to tell you about evaluation at Göttingen Medical School, and obviously I'm happy to take your questions. Thanks a lot.